Jaipur for the welcome and introductory note. It's over to you, sir.
Yeah, thank you, Horizon team. And I think yesterday session was very great. And yesterday we learned about this lung cancer. What is the newer in this lung cancer? So, as the second day of this theme of Oncology Perspective 2024 in the breast, GI, and GU cancer. So, without wasting the time, I invite Dr. Pulkit, who will deliver the talk on the newer updates in the management of first line biliary tract cancer. I think we know as the biliary tract cancer is treatment is very evolving. So initially chemotherapy is available, and nowadays immunotherapy options is also available for inoperable, advanced, or metastatic disease. And this session is also sponsored by the AstraZeneca. So over to you, Dr. Pulkit. I think
Thank
the
you, sir,
time
and good
limit is
evening.
15 minutes. Yeah.
Sure, sir. I'll
Okay,
just
okay,
share my
fine.
screen, sir.
Yeah.
Is it visible, sir?
Yeah. Screen is visible. Please
I'll
do in
make it full
PPT.
screen.
Yeah.
Okay, I'll start with my presentation, sir. So,
Yeah.
good evening and welcome all. So, my today's presentation is newer update in the management of first line biliary tract cancer. So, we all know the statistics that almost 30,000 cases has been reported in India, and there has been an increase in trend for incidence of biliary tract in both males and females over the years, although the females are the leading in the incidence of the biliary tract cancer. So what are this current management in the advanced biliary tract cancer? So we have three baskets in it. The first is a chemotherapy with the options of GemCis, FOLFOX, FOLFIRI. The second basket is the targetable mutations I'll discuss in the further slides. And the third basket do we have is the latest immunotherapy options, that is durvalumab, pembrolizumab, and now CAR T cell therapy and vaccines. So we all know about ABC2 study, like how GemCis has been established as a standard first-line chemotherapy for advanced biliary tract cancer. It is still remains the standard of choice with no newer therapies improving the outcome. That was before the pre-immunotherapy area. So I don't want to waste much time on it. So we know the comparison of GemCis versus GemOxy. The overall response rate, the EFS and OS was almost similar. It depends on the patient profile. If the patient have diabetes like neuropathy, then it favors the use of GC, while the lower incidence of hematological toxicities and the potential ease of administration, it favors in the favor of gemcitabine and oxaliplatin. So I think the response wise both are same, but on the patient profile, it depends which we need to choose. So this was the pre-immunotherapy NCCN guidelines. We all are aware of those immunotherapy, the chemotherapy options. And now this is the latest NCCN 2024 post-immunotherapy era guidelines. We can clearly see addition of durvalumab and the pembrolizumab. And in the metastatic disease, we have various targetable mutations and respective therapeutic drug. I'll discuss in detail in the further slides. So, which is like the first immunotherapy in the first line advanced biliary tract cancer. We all know about Topaz 1 trial. It is a phase 3 randomized double-blind placebo-controlled study of durvalumab. So basically, the design is like it's a phase 3 study of locally advanced metastatic biliary tract cancer with recurrence greater than 6 months after surgery or adjuvant therapy. And it's basically compared durvalumab plus chemo versus placebo plus chemo. And the durvalumab was giving 4 weekly and the GemCis were also giving 4 weekly until progressive disease for up to 8 cycles. So this was the patient profile. Most of the patients are in locally advanced and metastatic settings. And the ongoing treatment patients in Durva plus GemCis are 63 in the current data. And we can clearly see that how the difference in the median on survival between Durva plus GemCis versus placebo plus GemCis, which shows a sustained 2 year sustained and durable overall survival benefit. So the difference of median OS at 12 months was 54 versus 47 months. At 18 months, it was 34 versus 24. And at 24 months, it was 23 versus 11.5%. And with the significant p-value, it shows that once it's starting showing response to Durva plus GemCis, I think it will be continued for a longer time. With this, the patient profiling, I think the maximum benefit was seen in locally advanced status. And we look at this PFS benefit, then 7.2 versus 5.7 months with a significant p-value of 0.001 as being a superb results for Durva plus GemCis, and the 12-month PFS percentage range was 16% versus 6%. So I think it's a very good response of Durva plus Gem. Similarly, we have seen like the PFS benefit was seen favoring Imfinzi plus GemCis across all the subgroups, And the maximum benefit was seen in the locally advanced biliary tract cancer as per the forest plot. So this showed that a significant superior overall response rate within 1 in 4 patients which respond beyond 1 year. That is 24.6% versus 18%. So if a patient start responding to Durva plus Gemcis, I think the response becomes sustained and more durable for another 2 years. Yeah, this we have discussed. So yeah, this is I want to say that remaining in the response for greater than 12 months, then 26% versus 15% is the duration of response for greater than 12 months in Durva plus Gemcis. So that's what I said. Patient who responded continued to respond better and beyond 2 years. And among responders, there was a clear and sustained separation of curves beginning approximately 15 months after randomization. And similarly, among participants with the best objective response of stable disease, there was a sustained separation between the curves at approximately 6 months. So even at the stable disease point of view, the response of Durva plus Gemcis is better than placebo plus Gemcis. So no, if we talk about the side effects, I think only the immune therapy related side effects was add-on in Durva plus Gemcis. None of the side effects leads to the discontinuation of the therapy, and most of the side effects are in the range of grade 1 and grade 2. If we talk about the immunotherapy related side effects, they were there, but only few of them are like less than 2.5% patient experiences greater than equal to grade 3 immunotherapy associated side effects. So on the basis of side effects also, I think Durva plus Gemcis is a well tolerable regimen and it does not lead to the added toxicity. So, and also this is a slide which shows that the Durva plus Gemcis was associated with the OS benefit irrespective of the immune therapy associated side effect. So suppose patient have hypothyroidism, fatigue, any of the side effect, then it does not lead to the difference in the overall survival because the discontinuation rate was less and less than 2.5% has grade 3 effects. So this is the latest development in 2023. It was approved in the NCCN guidelines. So the conclusion about Durva plus Gemcis, it looks statistically significant, meaningfully progressed OSN as compared to placebo plus Gemcis, and it is effective across the all molecular landscape of BTC and patients with targetable genomic alteration. It did not lead to additional toxicity, and Imfinzi 1500 mg in combination with chemotherapy is approved in adult patients with locally advanced and metastatic biliary tract cancer. So Topaz was the first global phase 3 trial data to give positive results with immunotherapy in combination with immunotherapy. I think we have already seen the NCC in 2024 slide indicating as a category 1 recommendation for locally advanced and metastatic biliary tract cancer. The second latest edited immunotherapy trial was Pembro plus Gemcis. I'll quickly say on it. The eligibility criteria remains the same, histologically confirmed cholangio and gallbladder cancer. And the comparison was Pembro 200 mg with Gemcis versus Gemcis. And we can see that at the end of it was carried up to 36 months, the study. And the median OS was 12.7 versus 10.9 months. And the 12-month overall survival percentage was 52 and 24-month overall survival percentage was 25. So I think it's almost similar to the Topaz one. So pembrolizumab versus placebo, 6.5 versus 5.61 is the PFS benefit, which leads to combination now FDA approved with locally advanced unresectable or metastatic biliary tract cancer. We can see the separation of the curves. This is just a slide comparing Topaz 1 and Keynote 966 trial. And just on the basis of region, this is more in Asian. Intrahepatic were included more in Keynote. MSI high was more in Keynote. And this was just about HBV infection rate. So this was all about the two major immunotherapy trials, the Topaz 1 and the Keynote 966, and both leads to the major approval of the combination of immunotherapy with chemotherapy in locally advanced or metastatic biliary tract cancer. Now, what about the other genomic landscape? So it is a very large landscape, and we see that mostly in the cholangiocarcinoma. So FGFR2 fusions and IDH1 mutations occur almost exclusively in intrahepatic cholangiocarcinoma, whereas HER2 amplification in KRAS occur more commonly in perihilar and distal. So the therapeutic landscape has been transformed in cholangiocarcinoma with identification of actionable alteration in 40 to 50% of intrahepatic cholangiocarcinoma and 15 to 20% of perihilar and distal. So I think intrahepatic cholangiocarcinoma has the maximum of genomic alterations, and luckily and fortunately we have a therapeutic targets available for it. So this is the just a quick diagram to show the incidence of various targetable mutations in which NTRK fusion incidence is less than 1%. MSI 1 to 3, TMB high is less than 5, BRAF 1 to 5, RET fusion is very less than 1. So FGFR2 fusion or rearrangement is between 9 to 15% intrahepatic, and IDH1 in 10 to 20 in intrahepatic, and HER2 amplification is 5 to 20 and 15 to 30% in gallbladder cancer. So we all know that for cholangiocarcinoma, the two approved drugs for FGFR is pemigatinib and futibatinib. Both are FGFR receptor 1 to 4 kinase inhibitor. They have some difference in their mechanism. We can clearly see that the duration of response, the PFS, was 6.9 months in pemigatinib arm, but in futibatinib it was 9 months. The overall survival was almost same. So the indication was treatable, unresectable, locally advanced or metastatic cholangiocarcinoma with an FGFR2 fusion or other rearrangement. So the most important side effect has been hyperphosphatemia, and all patients should have a baseline eye examination before the therapy initiation because there is some dry eye, keratitis and conjunctivitis, retinal pigment epithelial detachment, and regular muscle cramps and myalgia. So hyperphosphatemia and regular eye examination before starting this drug is essential. These are just the comparison of the side effects. Now, if we see that the IDH1 mutations are mostly common in intrahepatic cholangiocarcinoma, we can clearly see that the blue line of IDH1 is very common in intrahepatic, whereas KRAS mutation is more common in extrahepatic, the orange line. Similarly goes for TP53. So KRAS and TP53 are more in extrahepatic. Rest of the mutations like IDH1 is most common in intrahepatic cholangiocarcinoma. So CLAR-DHY study comparison the drug against the IDH1 mutation is ivosidenib and versus placebo. So we can see that the 12-month response rate was 22%. We can clearly see the separation of the graph, and it is approved by FDA for treating with locally advanced metastatic cholangiocarcinoma with susceptible IDH1 mutation who have been previously treated. So I think it is mostly indicated in the second line option. So the safety regular side effect is nausea, diarrhea, fatigue, abdominal pain, cough. Most common is nausea and diarrhea and fatigue. So the trans2 plus per2 for HER2 positive biliary tract cancer, and also the median OS benefit we can see is of 10.9 months. The grade 3, grade 4 adverse effects are 46%. Most frequently was raised liver parameters. So this is the diagram showing the benefit in HER2 positive biliary tract cancer, the waterfall plot, that how effectively if we combine the trans2 plus per2 against the HER2 positive biliary tract cancer. This is another study of tucatinib plus trastuzumab for previously treated HER2 positive, and the results were better as compared to the placebo. The most common treatment-related adverse effect with dual HER2 inhibition is diarrhea, and similarly, as discussed before, that is the raised liver parameters, anemia, fatigue, and alkaline phosphatase. So also we know that trastuzumab deruxtecan has been approved in NCCN guidelines for advanced HER2 expressive biliary tract cancer, and we have two important trials. One is the HERB trial and one is Destiny Pan Tumor Auto trial, and both of them has shown that even in the low HER2, like the HERB trial has showed that in low HER2 there has been a PFS benefit as well as the median overall survival benefit. And in Destiny Pan Tumor Auto trial in IHC 2 plus status, the PFS and OS benefit was also around 4.6 to 7% in is the median overall survival. The side effects are same: anemia, neutropenia, and interstitial lung disease. So, like the classical side effect of trastuzumab deruxtecan, even in the breast cancer was ILD, and it has been seen consistently in biliary tract cancers also. So next is the BRAF and MEK inhibitors, and we all know how it works together. So dabrafenib, this is a ROAR trial. Dabrafenib plus tremetinib has been indicated as a second-line treatment with no satisfactory alternative options, with the overall response rate of 47%. So the another important is NTRK inhibitors. This is the pathway which NTRK pathway work leading to tumor cell proliferation. Yeah, the major NTRK inhibitors we know is basically the oncogenic driver in various tumor types, and the two important are entrectinib and sulfatinib. It is indicated in patient with advanced NTRK fusion positive solid tumor. So larotrectinib was evaluated in phase 1, phase 2 trial for patient with advanced NTRK fusion positive solid tumors. And the overall response rate was 79%, with complete response observed in 16%, and median PFS was 28.3 months. And I think the OS is very good of 44 months. So the Arrow trial basically uh, has checked about the pralsetinib, the newer generation oral selective RET inhibitors, and sulfaratepin has been tested in Libretto trial, and both of them have showed consistent overall response rate, OS, and PFS benefit. So these are the occasional side effects of neuropathy: congenital insensitivity to pain when anhydrous, leading to TRKA inhibition, and TRKB receptor inhibition leads to hyperphagia, hyperdipsia, dorsal root neuron loss, memory impairment, and TRKC inhibition leads to proprioception defect and motor neuron afferent loss. So these are one of the side effects. Most of them are grade 1 only. Grade 2 and grade 3 are rare. Thank you so much, sir. Thank you.
So thank you, Dr. Pulkit. So just want to one or two queries from my side.
Sure, sir.
Are you comfortable with this regimes Durva plus Sysjam, or are you using in clinical practice?
Yes, sir. I have one patient on Durva. So
Hmm.
I'll just a minute, sir. Sir, am I visible, sir?
Yeah, you are visible.
Okay. So, sir, I have one patient of Durva and Gemsys. The patient has already received Gemsys outside and came to with a stable disease. So, the patient tolerated Durva plus Gemsys very well, and she was alive for almost 11 months. But after 11 months, the disease started progressing. So, I had just have one patient with Durva plus Gemsys, and sir, one patient I have is a synchronous dual malignancy of a squamous cell lung with adenocarcinoma gallbladder with HER2 positive. And that patient have started on peclicarbo for lung with single agent gem plus trastuzumab for gallbladder.
Are only three molecular based treatment which is in process. Either it is a MSI for the immunotherapy, or a BRCA, or a HRD positivity or not. So so for the ovarian malignancy we are talking about, so the ovarian malignancy, where the patient is either a germline BRCA1 or BRCA2 positive, or a somatic BRCA1 or BRCA2 positive, or a HRD with or without the BRCA positivity is considerable. So with all those consideration, so if the patient is either germline or BRCA, somatic BRCA mutated, single agent, if we talk about just the olaparib is indicated in the maintenance setting after 6 to 8 cycles of chemotherapy, either neoadjuvant, adjuvant, or complete chemotherapy. If the patient is HRD positive and the patient is not having a BRCA positivity, the indication is approved with the bevacizumab. And in the recurrent setting, if the patient is having a platinum sensitive relapse, then it is approved. And fourth, whether there is a three or more than 3 lines of therapy. Study 19, which was the first study, whether at that time it was a capsule, and it was not for the maintenance, it was for the treatment as well. And other from that, olaparib is approved in breast cancer, prostate cancer, and pancreatic cancer as well. So if we talk about the ovarian cancer positivity, if we talk about, if we are seeing the germline positivity of the BRCA, it is almost from 13%. Going to the germline plus tissue BRCA, it is almost 22%. And if we going about the HRDs, almost between 45 to 50% of the patient do have a HRD positivity report. Uh, so again, moving forward with the first line maintenance therapy, olaparib with or without bevacizumab was approved in the 2018 with the BRCA mutated patients, only with a single agent olaparib. With the HRD positive with or without the BRCA, it was approved with the Paula-1 trial in 2020 along with the bevacizumab. Niraparib, although not approved and we have not used, it was approved across the lines of therapy. Either it was a BRCA or HRD, and along with that, if we talk about the rucaparib, it is also approved, endorsed, but not FDA approved till date. But yeah, it has shown the results at par. Either the patient is HRD positive or not, or BRCA mutated or not. So basically coming to the main trials, solo one trial for the olaparib showed in the BRCA mutated patient the hazard ratio 0.3. The HRD positive patients in the Paola one trial, it was those the patient who are having HRD as well as BRCA. Again, the hazard ratio is 0.3, but those the patient who are having a HRD positivity with the BRCA wild type was 0.43, and again those the patient who are having a HRD negativity along with the BRCA wild type, it was almost hazard ratio was 1. So no, probably no, not a good response. Again, the primary trial, again, niraparib is not approved, so I do not have any experience for that. And ethanomono trial, although showed a very good result in either the patient is BRCA mutated or not, HRD positive or not, but still, since the FDA approval is still pending, I myself do not use RUCA as such in these indications. So again, coming back to the olaparib, starting from the olaparib solo one trial, those the patient who were BRCA mutated had in the placebo arm, it was a 13.8 month of PFS versus overall survival of more than 56 months. And those the patient who are having in the Paula 1 trial, whether either the BRCA mutated. Again, the hazard ratio was almost similar. The PFS was between 17 to 21 months in the BRCA mutated arm or HRD positive arm, the placebo, versus in the treatment arm, which was olaparib with the bevacizumab, it was almost around 37 months. So intent to treat population, although showed a significantly higher response, but that was due to the inclusion criteria. But those the patient who are having a negative HRD or BRCA did not show any benefit. If we again talking about the if we see about the ethanomono trial, BRCA mutated patient had a PFS of 14 versus not reached, and HRD positive of PFS was 11 versus 28.7 months, which was not reached. And if we talk about the prima, again, similarly, between 8 to 10 months of PFS in the placebo, or between 20 to 22 months of the PFS in the interventional arm. So we all know about the solo one trial, the patient of advanced C ovary, either stage 3, stage 4, either high-grade serous or endometrioid carcinoma with the BRCA mutation positive. The patient who responded initially on the platinum-based chemotherapy, underwent a cytoreductive surgery, was randomized between 2:1 between olaparib and placebo. And in the primary updated trial, the PFS was not reached versus it was 13 months in the placebo arm, and the overall survival median PFS was median OS. I'm sorry for the typing mistake. Median OS was 56 months versus 13.8 months in the placebo arm. So this was it. 7 years of follow-up. 67% of the patient was still alive at the end of 7 years versus 46% in the placebo arm. And the conclusion said that there was a 40% benefit which showed with the PAR inhibitor therapy if we compare about with the chemotherapy standards with the hazard ratio of 0.55 and with the significant overall survival ratio. Again, if the Paolo 1 trial, whether those the patient who are HRD positive with or without the BRCA status, again randomized between olaparib with the bevacizumab. Again, the inclusion criteria was same, either stage 3 or stage 4 with the I grade, either serous or endometrioid carcinoma or fallopian or peritoneal cancer, which was randomized 2:1 ratio between olaparib to bevacizumab versus only bevacizumab with the placebo arm for 2 years, and bevacizumab was given for only for 15 months, and the median PFS was at the end of 5 years, it was 46% versus 19%, and the median PFS was 46 months versus 17 months only. And if you talk about the overall survival, median OS was 75 months versus 57 months, and the 75 months was also unstable because of the maturation data is not more than 50%. So patient benefited all across the data. The patient who are HRD positive, median OS was 75 versus 57, including those the patient who are HRD positive as well as BRCA mutated. Again, the PFS was OS was 75 versus 66, and those the patient who are HRD positive but are not having a BRCA mutation positive, median 5-year overall survival rate was 54% versus 44%. So again, irrespective of BRCA status, the inclusion of olaparib along with the bevacizumab give a overall survival benefit. But if we look across those subset of the patient who are having both HRD negativity and BRCA negativity, those the patient are not getting any benefit. So probably due to intent to treat population, the data is like that. But as far as now indicated, either HRD positive or BRCA mutated patients in the Paula 1 trial is a way to go again. And the incidence of MDS, which is a very significant side effect, is very low, and as a considerable option for the HRD positive patient and newly diagnosed and advanced ovarian cancer as a maintenance setting. So again, those the patient of stage 3, stage 4 who have not received bevacizumab in the first line setting, or the patient who are having a wild type, either observe or rucaparib or niraparib, or those the patient who are having a germline or a somatic BRCA1 or BRCA2 positivity, either olaparib or ruca or niraparib is the way to go. And those the patient who has already received bevacizumab in the first line setting, and those are who are having a BRCA wild type, then we have to see those the patient who are having a HRD positivity, then bevacizumab with the olaparib, HRD negativity, then only bevacizumab, and if BRCA1 or BRCA2 mutation, then either we can go with the single agent olaparib or olaparib with the bevacizumab as well. So relapsed ovarian, if you talk about the treatment of relapsed ovarian cancer, initially it was like partially sensitive ovarian malignancy, which was like relapsing less than between 6 to 12 months, or platinum sensitive disease was relapsing after 12 months, or platinum resistant disease, which is less than 6 months of end of the treatment. But though these lines are quite merging right now, but till date, for the maintenance setting in the second line for the PARP inhibitor, it is still the same. So coming back to again the role of PARP inhibitor in the management of relapsed ovarian malignancy, it has to be germline BRCA mutated, it has to be platinum sensitive disease. Just for the information, whether they have approved for the HRD positivity or HRD negative, it is for the study 19, which was initially approved from where the olaparib introduction started. So a solo 2 trial for the second maintenance setting in the after the second chemotherapy again showed a median PFS of 19 versus 5.5 months and median overall survival of 51%, 51 months versus 38 months. And study 19 was the the initial study of olaparib, where there was a capsule of that, and it showed a very good response. It was again compared between the chemotherapy and showed a very good response. And solo 2 again in the second line setting showed a hazard ratio of 0.3 in the PFS and hazard ratio of 0.7 in the OS setting. So influencing what are the factors in the PARP inhibitor choices? It can be a biomarker, dosing schedule, interaction, adverse effect, and the patient provided preferences as well as financial consideration as well. We all know the starting dose of the PARP inhibitors and the toxicity management. So, and if we talk about the toxicities, we can all the PARP inhibitors, if we talk about the olaparib is almost least having a side effects. If we talk about the cardiovascular, highest is the niraparib. If we talk about the skin effects, rucaparib is on the higher, and GI again the rucaparib. Hematologically again the niraparib. Again, if you talk about the liver toxicities, again rucaparib is on the higher side. If you musculoskeletal, renal, or respiratory, again niraparib or either rucaparib is on the highest side. So most tolerable PARP inhibitor till date is olaparib, and we do feel so in our clinical practice as well. And these are the monitoring criteria when we can hold either hemoglobin is less than 6 or platelets is less than 1 lakh or ANC is less than 1,000. We need to hold the drug, and there is a standard guideline. We are not going in the details with them. So thank you so much, Devesh sir, for giving me this opportunity. And
So thank you, Ankit. So what is your, are you doing the BRCA in all patient upfrontly?
sir, this is a very, very, so I do BRCA in all those patients who are quite affordable, at least for the olaparib or HRD, who are affordable only. If they're not affordable at all, I'm not pushing them for any testing.
I think this
Because
time financial consideration, but can we send upfrontly the sample for the germline initially, then we can decide for the HRD in upfront first line setting.
yes, sir. I'm sending first line setting from the starting of the treatment. Germline is I think so. I am a garibo wala doctor, sir. So I send free of cost germline BRCA
Yeah.
for all the patients.
Asim, is your thought about this, the ovarian cancer you are treating this segment in this Bhagwan Mahavir?
Ankit, Deveshji, we are sending and we are try to send in each and every patient now.
Okay.
And no doctor should be Garib, even if they treat the Garib patient. Doctor should be always like Dr. Somani. At least
You can
patient की इतनी
yeah.
बड़ी building दिखना चाहिए.
you can
Yes,
send
sir.
them to the government setup because they claim that each and every treatment is free of the cost and equally available to everyone.
Yes, sir.
So, sir, just let me complete my what you asked there. So, germline BRCA, I am sending for all the patients, just for the screening. And if the patient, if either affordable for 15 to 16,000 or 17,000 rupees of olaparib, we are trying to counsel them for the HRD or if the germline BRCA is positive, then there is no issue. So with this approach, I have almost managed 10 patients in quite like last 1 year. So I am having 10 patients of olaparib just because of this step by step. Dhire, 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 dhire.
So, sir, just want to ask, sir, is there any starting dose 200 BD or 250 BD or apparently 300 BD?
300, sir.
Can I ask a question?
Yes, sir.
Dr. Ankit and to Dr. Samar also, because he probably had the large experience of giving this drug. There is a typical scenario, stage 3 high-grade serous carcinoma, upfront surgery is done, beautiful surgery, everything is okay, and patient is receiving bevacizumab also. Now, on the one hand, you say that the rucaparib is for each and every patient, irrespective of the HRD of the BRCA positive. And you have the BRCA positive and the option of the olaparib also. So how you choose between the two situations? And if the rucaparib is there for every patient, irrespective of the HRD, what sort of the magnitude of the benefit difference you think that HRD positive versus HRD negative in context to the rucaparib versus olaparib? Ankit,
Should I start, sir? So, first of all, sir, rucaparib is not a good drug to tolerate with. Na? So, patient do have a very high dermatological reaction, diarrhea, and everything. So, if it is a germline or wild type BRCA mutated positive patient, I give them an option. If you are continuing the bevacizumab, you can continue, or you can just start with the single agent olaparib. I had a very terrible experience with the rucaparib. Although five out of five, only one patient is tolerating full dose. Otherwise, all four patients are discontinued because of the side effects. For the rucaparib, I'm saying, sir. Very terrible. Those the patient who are complaining that even the chemotherapy was quite tolerable than the rucaparib.
This is fact actually. Sir, we have tried once when the Olapari was very costly and when you were using Linparja. So that time we used to use the Rukapari, but
Yeah.
we all know like it's not a tolerable drug. One thing is not tolerable and other thing is the effect is also we can't see. Patient is symptomatic as we started and he remains symptomatic. She remains symptomatic. So this is a basic issue. So our trust is on the Olapari. Now the generic will come and we'll see how they works, but still the original one is good drug to tolerate and the effect we can see both the ways in the response with the treatment, the symptom and the duration of the symptomatic relief. So all are there. So we believe on that.
So dosing, if you start with 250 BD or 300 BD apparently?
300 BD. 300 BD.
Upfrontly.
And I must say, very rarely we need to reduce the doses of the this olaparib.
Okay.
I
And
agree
I'm
with
comfortable with this
Asim.
generic drug. Abhi, that time the drug was launched and you are giving, so you are comfortable compared to the research molecule?
Yeah, it is. It is
Sir,
comfortable.
I agree with Asim sir. I've seen like almost 70 to 75% patient, one third, two, three-fourth of the patient tolerate very well the full dose of the drug. And it is very early to say that whether the generic is doing good or not. But one of the patient waited after this, he has started the olaparib. She has started the olaparib in the second line setting, and she waited after the completion of chemotherapy for 3 months. And her CA-125 was almost around 75, but there was no radiological disease. And she started taking some generic, I do not know with the hot melting technique and everything. And within 15 days, the CA-125 came to 7. So I think generic is also working, but we cannot see the PFS and OS, but this is a small data like we can observe. So I think it is working. Or
Is there any difference of making this drug in the suppose some techniques are they some companies are claiming hot and back? I think I don't know.
सब वही कर रहे हैं सर, सब वही कर रहे हैं, वो सब मार्केटिंग है सर.
Okay.
Everybody is creating that only.
So thank you, sir, and thank you, Ankit, for
Thank
this
you, sir. Thank
talk.
you, sir.
And thanks, Jaidas, for this session. For this next session, I invite Dr. Asim Samar, the session is sponsored by the Merck. And the topic is the management of metastatic urothelial carcinoma. And he is the senior most medical oncologist at Bhagwan Mahavir Cancer Hospital. So over to you, Dr. Samir. The time is 15 minutes.
I will finish in 10-12 minutes.
Yeah.
So don't worry.
Thank you.
Okay, I guess the slide is visible.
Yes, sir.
The
Yeah,
slide
slide
is
is visible now. Go on the first slide.
He wants to show the last slide.
No, I guess.
अभी 12 मिनट में होगा बॉस.
Hello, Jitendra.
Yes boss, good
I will
evening.
start if they are moving, right? Good evening, good evening. So thank you, Dr. Devesh. I will speak on the management of the metastatic urothelial cancer. So we'll go on to the next. So this is the development of the treatment of metastatic urothelial cancer. Just let me set it. So first in 1980, cisplatin came as a rescue
I think,
molecule.
sorry, Asim. I think the first slide was not visible. I think this is the last slide.
No, this is first.
No, I think I am not seeing the first slide. Huh?
ये हमेशा ही problem करता है. Please. Okay, then somebody can have the control and start that.
Yes, sir. Yes.
Yes. Nishant, please.
So cisplatin. Now you can see the first slide.
Yeah.
Okay. Go on to the second slide then. We'll move further very fast. So this is the landscape. We need to spend like around 30 seconds on this. Cisplatin is a most active chemotherapy in the metastatic urothelial cancer, and it is a sheet anchor drug since 1980s. When the chemotherapy was developed in a very slower manner, and then after 12 years, then next combo has come with some other platinum agents. And with the 25 years of the gap in 2017, there is a development in this era, and the pembrolizumab and cisplatin were developed in the combination. Then maintenance avelumab after induction of platinum-based chemotherapy, it has approved in 2020, and that make a some noise in this area. When maintenance avelumab could increase the PFS as well as OS. Then checkmate 901 has come, where the GemCis, our favorite molecule, were combined with the nivolumab, and it has improved somehow PFS. And then again, this is the blockbuster drug EV 302 trial, where the enfortumab vedotin plus pembrolizumab has made some good survival advantage. Next, please. In 2023, and we all discussed this trial also. So Javelin Bladder 100, where it was a phase 3 randomized open label study, and the patient population was unresectable locally advanced or metastatic urothelial cancer with having the measurable disease, and they were in the stage 4 disease. They received standard first-line chemotherapy with the GemNCis or Gem or Carbo, and the therapy number of the cycle were 4 to 6. The patient got the response after 4 cycles, then they converted into the avelumab maintenance, and if patient could receive 6 cycles, it was fine. So the treatment-free interval was given 4 to 10 weeks after completion of the chemotherapy, but they didn't take the patient who had progressed over the platinum-based chemotherapy, because they were knowing like they are the worst subset of the patient which will not respond to the immunotherapy. So the patient were stratified according to the patient with CR/PR or stable disease, and they screened 700 patients, and out of them 358 patients, almost 50% of the patients were positive for the PDL1 positivity. Then they were randomized into 2 arms, avelumab 10 mg per kg, Q2 weekly plus best supportive care and best supportive care alone. And the drug was given till the progression. So primary endpoint of this particular trial was overall survival, and the secondary endpoint or the secondary endpoint was the PFS, overall response rate, time to response, and response duration. Next, please. So you see the median overall survival from start of the first line chemotherapy. It is not from the starting of the maintenance therapy. They measured the starting from the first line chemotherapy. with full javelin bladder regimen. It was given for the 30 month and setting a benchmark for current and future trials. So you can see if you give the avelumab maintenance, then patient's median overall survival was 29.7 months. And here, if you don't give and only best supportive care was offered, then it was 20.5 months. So there is almost clear-cut 9 month survival benefit was there. And it was statistically significant. HR ratio was 0.77, which seems like it is not impressive, not very much impressive, but it was significant. Next, please. So avelumab maintenance more than double the PFS as compared to the best supportive care. You could see if you give avelumab plus best supportive care, the PFS was 5.5. If you don't give and the best supportive care was offered, then patient will progress in 2.1 month only. And the HR ratio for the PFS was 0.54. So there was 46% benefit in risk reduction of the disease progression or death. And this is the survival PFS curve. You can see the avelumab arm does better than the only best supportive care arm. Next, please. So this is, you can see the comparison between two regimen. Patient had cis-gem or carbo-gem, but still avelumab maintenance does better in both the ways as compared to the best supportive care. But you can numerically see like cisplatin arm did better than the carbo-gem arm. And we know like carboplatin in the area of the urinary bladder cancer, it is weaker drug than the cisplatin, and this has been again reiterated. So OS benefit with maintenance avelumab seen from start of the first line chemotherapy regardless of the chemotherapy regimen, and the benefit was seen in the both type of the regimen. Next, please. So avelumab maintenance extended overall survival in all eligible patient, irrespective of the best response with the chemotherapy. So patient were taken like patient had complete response, partial response, and stable disease. But as we all know, if patient had a complete response, then they tend to do better than the patient who had the stable disease only. And this fact has been depicted in all the Kaplan-Meier curve. You can see patient had a complete response after the 4 cycle or 6 cycle of the chemotherapy. Then overall survival was 39.8 months, almost 40 months. And as compared to the best supportive care, it was 26.8 months, and the HR ratio was 0.72. If patient had partial response, this further overall survival was dropped down to the 9.2 months as compared to the 12.8 months in the best supportive care arm, and the HR ratio was 0.70. The avelumab arm was better, and in patient has a stable disease, then the overall survival has further reduced to 20.3 versus 14.0 months, and it was HR ratio was 0.84. So it is not that much impressive as that it is in the complete response arm, but still all the three subgroup had maintained the avelumab maintenance benefit. Next, please. So overall survival benefit was observed irrespective of the number of first-line chemotherapy cycles prior to avelumab maintenance. If you give after 4 cycles, or if it doesn't matter, or if you give after 6 cycles. So if you give after 4 cycles, overall survival was 19.9 months versus 13.7 months in the best supportive care. Here, if you could complete 6 cycles and have the response, then it was 24 months as compared to the best supportive care where it was 14 months. Hazard ratio was almost similar, 0.69 and 0.66. Next, please. So median PFS of 26.7 months in patient on avelumab maintenance for more than 12 months. So if you could deliver the drug for more than 12 months, then almost you have win the battle, because the median PFS is great and overall survival also better. So if you give 12 months here, if you complete this 12-month maintenance, then patient will have the progression after, most of the patient will have the progression after 26.7 months. Next, please. And if you give 12 months of the maintenance, then median overall survival was 4 years, which is unforeseen in the metastatic or unresectable urinary bladder cancer, which seems, or which we all accept that it is a lethal kind of the disease. But if you could complete 12 months of the maintenance, then median OS has not reached, and it is more than 4 years, which is very impressive. Next, please. In the Asian subgroup also, they represent 21% of the original trial population, and they all maintain the various parameters. Next, please. Next, yeah, Asian patients show similar median overall survival benefit as that of the overall patient population. So at the 24-month, you can say 60.7% patient had they were survived, and in the best supportive care it was 43.5 months. For 43.5% of the patient were surviving at the 24-month of the cutoff. And you can see the 3 times higher PFS compared to the non-available maintenance. If you don't give any maintenance, only best supportive care, then Asian patient had shown overall survival was PFS was 1.9 month, versus if you give maintenance, then they could progress after 5.6 months. Next, please. These are the common toxicities of the immunotherapy, which we all know. Pruritus or skin reactions, hypothyroidism are the most common. Diarrhea, infusion-related reaction, asthenia, fatigue. These are the common reactions which we all know nowadays. Next, please. So the efficacy of the Avelumab first-line maintenance has been confirmed in real-world heterogeneous population, and they have the data of more than 1,200 patients. So if you have the data of Javelin bladder 100, so 71.3% patient could survive 12 months. If you have the Evans data 65.4, then patient ready data is 69.2 months. The median PFS was 5.5 months in the Javelin bladder 100. Evans trial it was 5.7, and Ready trial it was 8.1 month. And median overall survival in Javelin bladder was 29.7. Evans trial it was 26.7. Ready trial it has not been reached to 50% level. Next, please. So this is the Evans study design. We can skip that. Next, please. Now again, they are seeing unprecedented 40.8-month overall survival with one of the largest real-world study, which was the Evans study. If patient has received first-line platinum-based doublet and had CRPR and stable disease and available maintenance was given, so then patient, you can see 1 year overall survival was 97%, and 2 year 81% patient were alive. And if you can use somehow N4 vedotin, then 40.8 month was the median overall survival, more than 3 years. Next, please. It is the comparative, you can see the other combinations also prevailing in this arena. Nivolumab plus gemcitabine and cisplatin versus gemcis alone for previously untreated, unresectable or metastatic urothelial cancer in the phase 3 Checkmate 901 trial. Next, please. It is important combination, but somehow in this slide, it looks like it is not important. Key inclusion criteria was more than 18 years of the patient, same patient population. It is previously untreated, unresectable or metastatic urothelial cancer involving renal pelvis, ureter, bladder or urethra. Cisplatin eligible patient they have taken up, and PS021, which is very standard for the international trials. And you can see the combination phase when the gemcis was given with the nivolumab. Nivolumab was given in quite a high dose, 360 mg on day 1, and the cisplatin was 70 mg per meter square day 1 only, and gemcitabine 1000 mg per meter square day 1 and day 8. Q3 weekly was given up to 6 cycles, then it was stopped, and Neo was continued as the maintenance, and maintenance dose was 480 mg Q4 weekly until progression, unacceptable toxicity withdrawal, or up to 24 months. And it was compared with the very standard arm Gemensis for the 6 cycles. And primary endpoint was the overall survival, PFS, and PFS by BICR. Second endpoint was OS, and exploratory endpoints were overall survival. Next, please. So you just see, if you use the combination of the GEMSIS at the 12-month, if you use only GEMSIS, it was 21.8% patient will not progress, and 2% patient, 34.2% patient will be having without progression at the 12-month. 24-month, you can see 23.5% patient will not have the progression, and here 9.6 month. So the Nivo plus GC have the better than the GC alone. Next, please. James is 7.6 month has the PFS. Nivo 7.9 month. But you see the trick is they have compared in the first 6 months only. But if you go further down, then the curve will separate further. Next, please. And you see the p-value is 0.007. OS primary endpoint, overall survival, it is better in the Nivo Gemcis arm rather than the Gemcis. And the p-value is significant, which is the test of the trial 0.017. Next, please. Gemcis is 18.9 month and Nivo plus CIS was 21.7 month. 2.8 month the median overall survival, but whatever it is, it was significant. Next. Subsequent therapies, it is always the question of the international trial. If you have used in this maintenance avelumab, what will you will give in the next progression? So subsequent immunotherapy received before PD, subsequent immunotherapy received at any time. So uses of the avelumab, I will read the last line. Properties of proportion of the patient receiving subsequent surgery, radiotherapy, and or platinum-based chemotherapy were similar in the Nivo GC or GC arm. Next, please. This is the important study and it is very much highlighted in this last year. EV302 or Keynote A39, where the two different drug companies' drug were combined together. It was open label randomized phase 3 study of N42 vedotin in combination with pembro versus chemotherapy in previously untreated locally advanced metastatic urothelial cancer. So we'll see what happens. And next, please. So if you don't consider the cost of this EV drug, EV, and you could give this EV plus pembro, then only concentration of having the side effect with the EV. Otherwise, every measurable point is better with the EV pembro. So let's see what was the design. Patient population previously untreated locally advanced or metastatic urothelial cancer eligible for the platinum, EV and pembrolizumab, PD-L1 inhibitor naive patient, and GFR more than 30 because they have given cisplatinum, ECOG PS less than 2. So they randomized into 1:1 patient, and the total population was 886 individuals. EV plus pembro, no maximum treatment cycle for EV, and they were used in the maintenance also till the patient can tolerate the EV. And maximum pembrolizumab cycle were given for 35 cycles. So, and it was compared with the cis or carbo plus gem. Maximum 35 cycles was given of the pembro. So EV 302 study, more than 78% patient had CR, PR or stable disease. And you could see in this down, you can say table, the CR rate in this novel combination was almost 30%, which generally is everyone will be surprised in the urothelial cancer to the metastatic or unresectable tumor. And partial response was 38.7, stable disease was 18.8. You see the two-sided p-value was highly significant. It was 0.4 times 0 and then 1. So overall response rate was 67% in the EV plus pembro versus the chemotherapy. Next, please. So it is a far-fetched dream to have this drug EV in recent future, but whenever it is available and we could see how better we can give this drug with controlled side effect will be there. So this combination may be the standard of care. So risk of the death was reduced by 53% in patients who received the EV plus pembro. And you can see at the 12-month cutoff, 78.2%, almost 80% patients were surviving with the Evo pembro. As compared to the chemotherapy arm, it was 61.4. And further, you see the graph is going wider and wider. And the median survival follow-up was 17.2 months. Next, please. So this is the soaring point of the study. Skin reaction was happened in 66.8% of the patient because EV also causes, pembro also causes. Peripheral neuropathy was there in 63.2% with the EV. We don't see peripheral neuropathy with the pembrolizumab. Ocular disorder were there, hyperglycemia, which is very troubling side effect, infusion-related reaction 2.0%. Peripheral neuropathy and ocular disorder monitoring is required. Any grade of alopecia, one in out of 3 patients. India is diabetic capital of the world. Hyperglycemia monitoring will be more crucial. Next, please. Yeah, so this is the now how we should go about this particular cancer. So overall survival, first line avelumab maintenance therapy, and second line EV leads to higher overall survival. And sometime later they will say if you use EV in first line, then it is more better. So this is TechMed 901 cis eligible only, Evo GC 7.9 month, and if you can survival time after first line therapy 13.8 month, total is 21.7 month. JB Javelin bladder, where you can use the platinum based combination, then you can use the maintenance therapy, then it is 29.7 month overall survival. If you use GEMC, Avelumab in the GEMC's treated patient, then it is 31 month. EV plus Pembro 12.5 and it is 31.5. Evans study showed you can use the drug afterwards also, and it is 40.8 month in the real world scenario. It is a cross trial comparison also. Next, please. So this is summary and take home message. Avalum maintenance more than doubled the PFS compared to the best supportive care, and this is in the unresectable metastatic urothelial cancer, which is by virtue it is a very lethal disease, very troubling, very symptomatic. Avelumab maintenance prolonged overall survival irrespective of the first line cisplatin based combination chemotherapy, whether you use cisplatin or carboplatin, both have the better overall survival. Avelumab maintenance extended overall survival in all eligible patients, irrespective of the best response with chemotherapy, whether it is CR, PR, or stable disease. In Javelin Bladder 100, Avelumab first-line maintenance had a manageable safety and tolerability profile with the low discontinuation rate. Real-world evidence of the consistent and efficacy and safety seen in the JB 100. Nivo plus GC, although a positive study, but result in a very minor increment in the PFS or overall survival, which you and may also disagree because it also works better. Pembro plus AV data looks good, but they have not compared in the standard of care, and one needs to be cautious with the toxicity profile of the AV, and especially in the combination also. And finally, sequencing of available option is the key. EV after first and Avelumab maintenance resulted in the unprecedented overall survival of the 40.8 month in this kind of the lethal disease. So next. So thank you very much. And if any question, I would be happy to answer.
Yeah. Thank you, Asim bhai. And just want to ask, are you using routine
Avelumab maintenance.
Avelumab maintenance?
Yes,
Yeah.
yes.
So in each and
So
every
whoever
case,
is supported by the empanelment, we use this.
okay.
And it
Okay.
is not available in RGHS, so most of the chunk patient are just out. But in the other empaneled thing we are using.
So just muscle invasive patient comes to you in your OPD and NACT was given. The 4-cycle cis gem was given, and there is the very good response. And patient is not willing for radical cystectomy. Then what is the next option?
Then you will give CTRT.
If still he is not willing for CTRT, then Avelumab can be given as a maintenance in that scenario.
No, if he is not willing for the curative treatment, then he might not be willing for the NACT also then.
Suppose some patient can take the photo.
Then nobody knows, because if the gross tumor is there, what happens with this kind of the chemotherapy? Though they say like the CR rate was there, but very rarely we could see like CR is there. And they ask for the data also before approving the drug, so we can't produce the data for the NACT followed by the Avelumab maintenance.
In last
Even
week,
if they got the radiological CR.
I have seen 2 patients, but they are not willing for surgery and they are not willing for CTRT. Then what next? So I am confused.
But Avelumab is not a cheap drug to use without the permission of the authorities.
Yeah.
It's quite a costly drug. So then you can complete with another 3-4 cycles, which you have left with the NACT, and then give some chemotherapy maintenance.
Okay. Sir, is there any thought?
Kumani sir, आपसे पूछ रहे हैं.
No. I mean, difficult to answer this question because of the cost, side effect, and the legality. So probably give the treatment-free period to the patient and watch and wait.
Okay. So we will, sir, actually the patient is 80 years, 82 years patient. We have given the 4-cycle of NACT. Now they are not willing for CTRT or suppose some sorts of this surgery. Then what next? So little bit confusion in my mind.
No, but Dr. Devesh, the treatment is decided upfront when they were presented in the tumor board or something. Some surgeon had seen. If they denied there, then there is no point in giving NACT also. It is palliative then.
Acha, we will continue in the palliative settings.
Hmm.
So with this Avelumab maintenance, so what times you have expend 2 years, 3 years the maintenance treatment in your practice?
No patient has completed till 12 months.
Okay, so there is early recurrences in spite of this maintenance treatment.
No, they have not recovered. One patient died, but other have not this, you can see the recovered or progressed, but they have not completed.
So maximum time you have gained 11 months, approximately 12 months.
No, they are still alive.
Okay,
They are on treatment actually.
okay. So, sir, any thoughts about this metastatic urothelial cancer?
With almost no experience.
Yeah. So thank you, Asim bhai, for this talk. For this next session, I invite Dr. Somani sir, who is the director and HOD in the Department of Oncology at HCG Cancer Center, and we will start this breast session from sir. And so adjuvant treatment of HR positive, HR2 negative, HER2 negative early breast cancer. So over to you, sir.
So, good evening, everyone, and thanks to Dr. Devas Goyal to give this opportunity. And I have been assigned to talk a little bit about the integration of CDK4 inhibitor in the early breast cancer. Now, this topic is important because presently we have the 3 drugs CDK4 inhibitors, all approved in the metastatic setting. We have the good experience, and 2 of these drugs now shifted in the neoadjuvant, in the adjuvant setting also for the management of these patients, especially the high risk HR positive patients. So it becomes very important to understand how to select the patient for this particular group of the drugs and how to give the priority or the importance to the one drug over the other in a given clinical situation. So if we talk about the the risk for the early breast cancer recurrence, we know that 20 to 30% of the early breast cancer, in spite of being the HR positive, HER negative, they have the risk. And these risks are dependent on the biological factors. These risks are dependent on the simple factors like the anatomical, like the tumor size, the nodal presence, and the various other parameters. So we need to identify these patients and try to give them the more treatment in spite of having the HR positivity. Now, this distant recurrence is strongly correlated to the nodal involvement in the diagnosis. More the number of the nodes are being diagnosed, more these patients will keep having the local as well as the distant recurrence also. So obviously for these node positive patient, endocrine therapy in adjuvant setting alone may not be the sufficient enough to prevent their cancer from the recurrence, and they have probably the very high chance of having the recurrence. So current concepts of improving the results in the adjuvant setting in the HR positive patient, we all understand that we try to give them the ovarian function suppression. We try to give them the sequential treatment, tamoxifen followed by aromatase inhibitor, something like that, to go to the 10 years or even the tamoxi for 10 years. And the newer approach, which may be like what else we can give for these patients. So this is the way that we can try to improve the results of these patients. Obviously, this is the unmet need and there are the gaps in the current treatment of the early breast cancer who are at the little bit on the higher side of the risk. Now, the disappointing aspect is that as far as the new drugs are concerned, there is a hardly parallel improvement in this subset of the patient, contrast to the HER positive patient, triple negative patient, BRCA patients, so far similar situation in the HR positive early breast cancer in this particular scenario. So if we go by the clinical trials available of the various CDK4 inhibitors in the adjuvant setting, the palbociclib-based 2 trials are worthy to mention, that is the PALAS and the Penelope trial, which both failed in the primary endpoint as well as the various secondary endpoints. The trials based on the abemaciclib, that is the Monarch A and the Natalie trial, they have moved advancement in this particular field. And as on today, the Monarch is being approved for this particular indication. Natalie E, that is the Novartis trial of the ribociclib, has also shown the improvement in the invasive disease-free survival. Now, this I am talking cross-trial comparison. I am not giving the direct comparison of the 2 molecules or the 2 drugs. So, coming to the Monarch A study, which we all understand, HR positive, HER negative, node positive. Now, the basic difference between the two groups of the trials is that monarchy basically talks about the nodal positivity. The simple rule of the thumb, based on the nodal positivity more than 4 or 4, if patient has a 1 to 3, then the other risk factors need to be there to consider the patient for the adjuvant CDK4 inhibitor. So this is a simple trial that once you finish the local treatment, new adjuvant treatment, including the adjuvant treatment based on the chemotherapy, when you go for the adjuvant aromatase inhibitor or equivalent drug like tamoxifen, at that time you add the abemaciclib 150 milligram for 2 years. Now, the primary endpoint of this trial is the invasive disease-free survival and the distant recurrence-free survival, and thus other other efficacy endpoints were taken in this. And if you look at the 5 years data, as far as the primary point is concerned, there is a gradually improvement in the outcome. That means, in spite of giving it only for the 2 years, there is a further subsequently, even when the patients are off treatment, there is the improvement in the primary endpoint. And so is the, at 5 years, the risk of the distant metastasis continue to decrease beyond the 2 years period of the exposure of the abemaciclib. So that is very, very important to understand that it is not only during the first 2 years when the drug is being exposed that the patients are being benefited. It is their continuous benefit subsequently also. So what the recent 5 years update of this particular trial says, which was presented a few months back in the October 2023 at the ISMO, that yes, its results are consistently being shown and has passed the primary endpoint, that is the invasive disease-free survival. So the various side effects are also there, which also remain our concern. And the points which come always in our mind is that when we try to reduce the dose, is there similar efficacy in the adjuvant setup? And it has also been shown based on the various data that when you go beyond 150 to 100 milligram, probably their efficacy in the adjuvant setting remains almost the same. So at the 5 years, what this trial concludes, that is the patient who are at the high risk of the recurrence, invasive disease-free survival benefits continue to deepen further, and adverse events were reversible and manageable, and safety parameters remains almost same what the data previously being given about this trial. Now coming to second positive trial, that is the Natalie trial based on the ribociclib. So that's again the more or less similar overlapping indications of the parameters of the patient are there. But this trial doesn't talk only about the anatomical node positive patient. Obviously, the node positive patients are there, but even with stage 2 patients who are node negative, based on the various risk factors, these trials also include the other parameters. Now, this trial, because the drug schedule is 21 days rather than the continuous, and they have reduced the dose from the standard dose in the metastatic setting from the 600 coming down to the 400 milligram to improve the toxicity, and they have increased the duration of the exposure from the 2 years to the 3 years. So these are the two important parameters about this particular trial. So it is covering a broader population of the patient, not only the node positive patient. The drug is the 400 milligram, and it is 3 years exposure to this particular drug. Now, parameters, primary endpoint remains the same, that is the invasive disease-free survival. Again, this trial is showing the positive results. The anatomical stage-wise, if we try to analyze, both stage 2 patient and stage 3 patient are being benefited as far as the primary endpoint for the ribociclib is concerned. Obviously, the nodal status positive patient also remains benefited by this particular combination also. And so is the distant disease-free survival also. So coming to the overall survival, which always remains a sore point for the discussion, for the trials, and most of the time it remains the secondary endpoint. But we always try to talk that until there is the overall survival gain, probably it's not worth practicing it. So the data for the overall survival for this trial as on today remains immature. Larger data are required because to gain a 4 to 5%, which is being expected in the adjuvant setting, to further enhance the results, probably a longer follow-up is required. So adverse events and the other parameters, if we compare, this is the overlapping population, not exactly the same population. It's again the cross-trial comparison, the toxicity the indication inclusion criteria, they are little bit different. Adverse events for the both these trials here remain the concern. The individual drug adverse events are there. If you talk about the ribocycline, we see that the few liver toxicity are there to the tune of the 8.9%. Arthralgia is another concern with this particular drug. And the important 2 points which this particular trial, ribocycline-based trial, try to bring is the patient-related outcome and the health of the quality-related parameter. These 2 points are broadly missing in the abemaciclib-based clinical trial. So the physical functioning scale based on the quality of life parameters being studied, and this particular trial try to say that the health-related quality of the parameters and other patient-related outcome remains stable. So another question which comes as the validity of the surrogate endpoints. This is the point I am bringing for the discussion in front of all the who are participating today. That do we always concern the surrogate endpoints important for our clinical practice, like invasive disease-free survival, distant survival, patient-related outcome, health-related quality of parameters, overall survival. So that what trial says to get its approval or the positive result versus in the clinical practice may be a little bit different. So partial overlapping indication of the two CDK4 inhibitors are there. So how wisely we can choose between the two for the individual patient depends on the many factors, that who will be benefited for the treatment in the given scenario, how much drug is needed, what are the potential downsides in terms of the safety as well as the tolerability. So these things we need to keep in the mind when we prescribe to the individual patient. So the choice between the two will depend on so many factors. Like if we talk about as on today, regulatory approval, which is more with the abemaciclib, drug access, depending on the cost factor, risk of the recurrence of the individual patient, long-term safety data or efficacy data, available safety profile, and obviously the patient preference based on the schedule and the toxicity profile. So many new points which are emerging, which are coming in my mind, the clinical scenario which we still need to answer when we prescribe this sort of the treatment. Is there still a need for the adjuvant chemotherapy for the HR positive patient? Let's say the patient is stage 2 or stage 3, and you have done the upfront surgery, or you are thinking to do the neoadjuvant chemotherapy, and you are thinking that the patient can go for the adjuvant CDK4 inhibitor. So in that clinical scenario, what the role for the neoadjuvant, including adjuvant chemotherapy, will be there? Those patients who are the BRCA positive and high risk, so what can be the role for the individual drug like the adjuvant olaparib? What should be the sequence? What should be the preference? Patient-related and long-term safety. And do not forget that many of these patients, being the younger, they have not completed their family. So what can be the gonadal toxicity or the oncofertility issues? And important question which will be coming more and more in the future when you expose these drugs in the adjuvant setting, what role they will be playing in the metastatic setting if many of these patients will be having the relapse despite of being exposed in the first line. So how the ISMO guidelines are helping us in this particular situation, that is, if you have the HR positive patient, if it is like luminal A-like picture, low risk, go ahead with only the single agent adjuvant endocrine therapy. But if the luminal patient, high risk patient, or luminal B-like of the patient, you have given neoadjuvant chemotherapy or adjuvant chemotherapy, and the patient is stage 3 or the high risk is stage 2. Depending on the germline BRCA testing and the availability of the information, if it is wild type or untested, go ahead with the aromatase, endocrine therapy along with the CDK4 inhibitor, that is the abemaciclib. If germline is mutated, stage 3 or the high risk stage 2 patient, not pathological CR, probably it's better to go for the olaparib. Now the point comes here for the discussion that both these positive trials, their period of the adjuvant may differ. Up to 6 months you can enroll, but the olaparib need to be given for the 1 year. So still you want to give them sequentially. Can the patient tolerate the toxicity of the olaparib in combination with the CDK4 inhibitor? So these are the still points we need to answer ourselves And we need to see that are the new trials are going to give us these answers. With this thought process, I would like to complete the presentation. Thank you.
So thank you, sir. Sir, so there is a practical experience. Are you using, sir, upfrontly in this high risk setting?
Yeah. So I'm still more in favor of the abemaciclib because of the regulatory approval. That is the reason for that. But 400 milligram of the this ribociclib looks attractive because we all understand the toxicity profile with the 400 milligram is more manageable, more appealing, and it gives you the drug holiday period of 7 to 10 days also.
So, sir, do you feel that ECG abnormality with this ribociclib? Are you discomfortable with this ECG abnormality with this ribociclib?
It's a concern. The moment it goes 45 to 46 milliseconds, at least my heart starts beating extra, and I start getting the premature ventricular contraction. It's a problem because the problem is there are a lot of drug interactions with the ribociclib. There are certain food restrictions also. Patient may be hypertensive, may be taking some drug, and this may lead, unfortunately, the sudden cardiac death.
Okay.
So that's a big concern. It is not the concern of the myocardial damage, which you can maintain sudden toxicity. The basic problem is the sudden cardiac death with the prolonged QTC.
Sir, any concern of loose motion with this abemaciclib?
So that is manageable. You can reduce the dose, you can give the loperamide, you can educate the patient, dietary modification. So that is actually more you educate the patient, less will be the toxicity.
Sir, is there in future the use of this adjuvant CDK4 is expanding more and more in numbers?
Yes, it will be obviously kind of the pair program which they are offering, and maybe that in the near future when the ribociclib will be more accessible based on the cost factor, I think it will be increased. And if we look at the cost of the so many other drugs, I don't find any reason not to use in a given scenario of the patient. My criteria remain very simple. Stage 3 patient, they are eligible. Stage 2 patient, you try to find out in the real sense, are they really at the high risk? Do they deserve this sort of the 4 to 5% of the possible potential increment in their outcome?
Sir, is there any age criteria to, deciding for this adjuvant CDK4, 40, 50, 30
So
or
probably
60?
beyond 65, I don't try to give it. But
Okay,
these patients have a lot of toxicity, which are difficult to manage. Support system always doesn't remain so accurate for the, let's say, 70 plus patient. This is a day-to-day problem.
Okay.
I usually try to avoid giving this sort of the counseling for the elderly person.
Okay. Thank you, sir. Thank you, sir, for this talk. Any query from Jitendra from your side? Your experience?
I found Abama is a very tough drug to give. Probably I'm in a learning phase to give Abama. But yes, definitely only the drug which is having approval in adjuvant setting is Abama. So we have only this thing which we can.
So thank you, sir.
And I find the BRCA as the more appealing marker because that's more like the definitive predictive marker.
Yeah.
And for CDK4, it's just based on the endocrine receptor expression only. So exact predictive marker is not there. So whenever you have the BRCA positive, I think that it's better to go for the PARP inhibitor rather than the CDK4 inhibitor.
So thank you, sir, for your inputs and for nice talk and nice presentation. And for next talk, I invite Dr. Jitendra. This is the Astra sponsored session, and he is medical oncologist at HCG Cancer Center, Jaipur. And the presentation on the trastuzumab deruxtecan in the treatment of HER2 low positive breast cancer. So over to you, Dr. Jitendra.
Thank you, Devesh boss. A very warm good evening to everyone. Can somebody share the slide? So probably Rustican will be the new wonder drug in the kitty as the data suggests us because the data is very beautiful and it has changed our DM training teaching which we usually hammered at every level that HER2 plus do a phase. If it is negative, it is negative. There is no role of anti-HER2 therapy. So having said that, we will sail through the data available and how we can use this drug in our current scenario. Next slide, please. So these will be the topics. As I already told that we are hammered during our DN days that what is HER2 positive, but HER2 low is a new drug, new thing in the kitty. So we'll discuss that. Then how the drug works. Then the second line Destiny Breast 04 study design. We will see how the drug has shown the efficacy, safety, and quality of life. Then how to modify the drug because it's a new drug in the kitty. And basic AE management, which we probably learn better when we use the drug, but still few drugs, few side effects are newer than other anti-HER2 agents. So we'll discuss in brief, and then we will discuss the practical administration guidelines, and then we will move to summary. Next slide, please. So as you all know, next slide, please. As we all know, that estimated 5-year survival across the globe is around 25% in metastatic breast cancer, and it remains an incurable disease. Even in the hormone receptor positive setting, it becomes a chronic disease, but it is still a non-curable disease. Next slide, please. So this is what we are taught, that you do a ERP or HER2 key 67 in each of every of the patient. If IHC 3 plus, it's a HER2 positive. IHC 2 plus, it's you have to do a FISH by fluorescent in situ hybridization. If it is positive, then it is HER2 positive, treat like that. If it is negative, then it was HER2 negative around 2 years back. Next slide, please. So coming to the more scope of the drug, which is hormone receptor positive treatment, which we usually think or say our patient in routine OPD that this disease is manageable. We have effective treatment even without chemotherapy. Having said that, if we see the data, then we will probably see that if patient is having hormone receptor positive disease, the first line treatment will control the disease for 28 months, second line for 16 months more, and third line will be 66 months or less months. So, and if you go to the hormone receptor negative, or the patient who are actually not hormone responsive, which is a 30% of the patient which progress on whatever combination we give with hormone. So these patients, first line treatment will suffice for 8 months to 6 months, then second line treatments will fall below 6 months to 2 months, even with the advanced therapy, and third line treatment is 2 months. So median survival with TNBC is 10 to 13 months. Next slide, please. So coming to the Destiny Breast 04 study design. So here what they came up with is that if a patient who is a HER2 low expressor, what they meant by HER2 low expressor, if it is IHC 1 plus positive or if it is IHC 2 plus and ISH negative. So which were negative previously, they told that it is HER2 low, and they try the agent in Destiny 04 study into this, and this constitutes 50% of all metastatic breast cancer, and this has opened a new arena for our patient for treating them with a targeted therapy. Next slide, please. So next slide, please. So here we can see that HER2 low background is around 50% of the patient in metastatic breast cancer setting. Next slide, please. So how this TDXD work actually? So it's a basically antibody drug conjugate, which we standardly understand, and the most commonly used drugs are TDM1, which we already have. So here we have a HER2 directed delivery agent, which actually have two main things. It has a more potent topoisomerase 1 inhibition payload, which is 10 times more potent than the irinotecan itself. And the membrane permeability of this agent allows the agent to diffuse across the cellular membrane and kill the adjacent drug via uh, site, via abscopal effect. Second thing is the tumor selective cleavage linker. So these drug molecules release the linker when the drug reaches into the tumor cells only. Next slide, please. So here we can see that the target is HER2, the antibody which we all know that are trastuzumab, and the payload is exatecan derivative, which is a topoisomerase 1 inhibitor. The antibody drug to drug ratio is 8:1, and the linker is cleavable, which is tumor selective, and there is evidence of a bystander effect because the payload is actually here in a lipid solubility, so it goes to the adjacent cells and kill more cells. Next slide, please. So here the agent works. It goes into the binds to the R2 and it goes to the endocytes. It is internalized and the linker breakage occurs through the action of lysosomal enzyme, and it gets released through the cleavage. And DDXT causes the targeted DNA damage and apoptosis by isomerase 1 inhibition, and it causes the neighboring cells also to kill because it is lipid soluble agent. Next slide, please. Next slide, please. So coming to the Destiny Breast 04 study design. Next slide, please. So here it was a phase 3 open label multicentric trial where HER2 low patients which were unresectable or metastatic breast cancer have been exposed to at least one line of chemotherapy in the metastatic setting. Patient with hormone receptor disease positive or considered who were endocrine refractory and who received a chemotherapy in the metastatic setting or have developed disease recurrence during or within 6 months of completing adjuvant chemotherapy. Patient with hormone receptor positive, this must have received more than one line of endocrine therapy. The study design was 2:1 randomization to TDXD, which is a dose of 5.4 mg per kg every 3 weekly, and with the physician choice chemotherapy, which usually we give capecitabine, eribulin, gemcitabine, paclitaxel, and nab-paclitaxel. So the primary endpoint was PFS. The key secondary endpoint was PFS for all patients, OS for hormone receptor positive, and OS for all patients. Additional secondary endpoints are safety. Next slide, please. So these are the demographic data. In the interest of time, I will just briefly say that these were well balanced, well maintained, and almost equal patient was HER2 1 plus and HER2 2 plus, which was each negative. Almost 40 patient in the HER2 cis negative arm, and almost 58 to 60% patient in the HER2 1 plus arm. And almost all the patients were hormone receptor positive. Negative were very less. Next slide, please. So with the metastasis rate on brain metastasis patient was almost similar in both the study. Lung patient was almost similar, 30%. Liver was also similar, slightly more in the TDXD arm, 70% versus 66%. Next slide, please. So coming to the lines of therapy, so this was also well balanced, as we can see with the forest plot of this bar diagram. Next slide, please. So the efficacy data, next slide, please. So coming to the primary endpoint, which was PFS, so as we can see that TDXD, the median PFS was 10.1 months. With the chemotherapy, as we all know, it is nearly 6 months in various metastatic first-line settings. And if we can see the OS, so the OS was almost 24 months versus 17.4 months in the chemotherapy alone arm. So as we can see that almost doubling of the PFS in the TDXD arm, and the the almost 6 months improvement in the overall survival in the and the p-value was significant in both the analysis. Next slide, please. So in all HER2 low patients, the hazard ratio of HER2 low MBC in all patients were similar in TDXD arm versus chemotherapy arm in the independent review analysis, as we have seen in the previous slide. Next slide, please. So as we can see that in this forest plot, that all the subgroup were failing with the TDXD arm, except the race, where the patient was only 37. That's why probably the confidence interval was higher, and it was not on the similar side of the TDXD. Next slide, please. So TDXD triple the ORR response rate, which was never imaginable in this sort of setting. Almost 52% percentage of response rate in the hormone receptor group and 50% in the hormone receptor negative group. On the comparison, chemotherapy was having a merely response rate of 16%, and the duration of response was also almost double or 150% of the standard chemotherapy. Next slide, please. As you can see that there was a huge response rate also in IFC 1+, 2+ patients, whether they were hormone negative, and we can see that there was deeper responses also. Also, we can see that CR was there on the tune of 8 to 10%. Next slide, please. So the mandatory subgroup I showed that there was hormone negative, HER2 low MBC patient also shared response with improvement is median PFS was 8.5 months versus 2.9 months with the hazard ratio of 0.46 with median OS improvement in this negative subgroup, hormone receptor negative subgroup was 18.2 months versus 8.3 months, and overall response rate as we have seen that 50% versus 16.7 months. Next slide, please. Coming to the safety data, next slide, please. So nausea, as we all know that usually the antibody drugs are mild to moderate emetogenic, but here this drug is one thing to monitor that this drug is highly emetogenic as per Haskell. So the most common side effect which was seen was nausea, then followed by fatigue, and there was skin reactions which was there, alopecia and neutropenia was also seen with this. And one more significant side effect which we will see with this is ILD. Next slide, please. So pneumonitis, including grade 5 cases, are reported with TDXD in Destiny breast 04. Although the majority side effect was grade 1 to 2, but yes, there were few patients who had grade 5 side effect. Means the number was 3, and other patients, almost 40 odd patients, did have the side effect which were grade 1 to grade 3 in pneumonitis. So almost 12% patient had pneumonitis, and grade 3 were 5, and 82% patient of ILD were grade 1 or 2. Median time to onset of pneumonitis was 129 days. It can be seen at day 26 from day 710. So pneumonitis is a concern with this new drug. Next slide, please. So coming to the quality of life data.
Jitendra, sorry, slightly the slide fast.
Sure, sir. Next slide, please. So quality of life in the form of and the fatigue parameters, nausea and vomiting were almost well managed as per the URTC 12C C30 score. Next slide, please. Coming to the dosing and distribution. Next slide, please. So as we all know that the recommended dose is 5.4 mg per kg every 3 weekly, and the initial dose should be administered at 90 minutes. And if the prior infusion is well tolerated, we can give the next dose in 30 minutes. Next slide, please. Coming to the dose modification, if patient had side effect, then we can go to the first dose reduction of 4.4 mg per kg. If there is further side effect, then we should go to 3.2 mg per kg, and then we can discontinue the treatment. Next slide, please. So coming to the dose modification for specific ADRs. Next slide, please. So if ILD grade 1 pneumonitis is there, we should interrupt, and if resolved within 4 weeks, we should reinstate the drug with a lower dose. If it is grade 2 or more, we should omit the drug. Neutropenia, if it is grade 1 or 2, we can probably interrupt. Grade 3, interrupt until resolved grade 2, and there is a need of dose modification. If there is a febrile neutropenia which is documented, then probably we have to interrupt the drug and dose interrupt. If there is grade 3 thrombocytopenia is there, till grade 3 we should interrupt the drug and then probably maintain the same dose. If grade 4 is there, probably we should decrease the drug by 1 parameter. Next slide, please. Coming to the ejection fraction, so probably we all know with the trastuzumab, how to monitor this and how to do this. Next slide, please. Coming to the AE management, next slide, please. So I will just brief about the everyone knows about the nausea and vomiting. So I will just brief with the data of ILD, which is a new side effect. As we know that it is a highly emetogenic agent, so we should manage it as such. How we manage a highly emetogenic drug. Next slide, please. Next slide, please. So coming to the ILD, so there is an ILD, we should actually monitor each patient with SpO2 before each cycle and probably some breathing test like a 6-minute walk test or some single breath count test. And probably we should do DLCO every 3 months, in between every 3 cycles. And if the patient has ILD and we should do also HRCT after every 3 cycles to monitor for ILD. Next slide, please. So for ILD, first thing is drug discontinuation. Then probably immunosuppressive therapy, what we give for various ILDs like steroid. We can give antibiotic for concomitant infection, and we can use Supron to rule out or control opportunistic infection. Supportive management, as we will do for ARDS, and probably majority patient will respond to the treatment, and then probably we can monitor with the help of a pulmonologist. But the bottom line is we have to monitor for ILD so that we can manage the patient better. Next slide, please. So this is a summary of what we had discussed. Next slide, please. So we have to do monitor, lung examination, respiratory function test, oxygen saturation, and HRCT as I have discussed. Next slide, please. Next slide, please. So this is an example of a patient. She was 49-year-old and she was diagnosed with CA breast, which was in February 2021. She was hormone negative, HER2 positive. She was clinically T4N2M0 BRCA positive patient, which was germline. So she received standard AC followed by Taxol, underwent right MRM, NALD. Next slide, please. Then she swelled up within 6 months, right side of the chest, a local disease, and there was a subpectoral axial lymph node and bone mets were there. Next slide, please. So as we know that she was, next slide. So there was again a biopsy was done, which was ERPR negative, HER2 2+ FISH negative, PDL1 CPS was more than 90%. So she was TNBC with CPS of 90%. Started in November with Pamro, Gemcitabine, Carboplatin. Next slide, please. So she progressed in May 2020 within 6 months of the treatment. Next slide, please. Since she was BRCA positive, she was started on olaparib in January 2023, and at the end of May 2023, she developed new bone lesion, and there was new pulmonary nodules which were evident PET-CT. Next slide, please. So she was started in June 2023 to TDXD. The first staging scan was almost CR, and patient was in CR for next 6 months. Next slide, please. So to summarize, next slide. So there is the first. So TDXD is the only HER2-directed therapy to provide significant survival benefit to patients with HER2 low and metastatic breast cancer after progression on standard therapy. So it nearly doubled the median PFS, 6 months or more increase in median OS, and almost 3 times of the overall response rate. So this is a drug which probably will evolve over the time. For now, timing is a second-line drug in a HER2 low patient. That's all. Thank you.
Yeah. So thank you, Jitendra. So what you consider HER2 low upfront, or if the patient develops recurrence and then the tumor nature suppose comes to be negative. Suppose first time the HER2 is 1+, then recurrence adjuvant treatment was completed and the recurrence was developed and repeat biopsy was suggestive of triple negative. So do you consider HER2+1 in upfront setting or the recurrent setting?
Was probably if we are able to do biopsy and it is negative, we should treat like negative.
Okay. So still consider in this case, if the biopsy was not done, then we can consider the upfront.
if it is mono disease, we are not able to do biopsy. Patient was hormone receptor positive upfront. We have given because my problem was that the patient who 70% was beautifully responding to any hormone receptor therapy with CDK4 inhibitor. The problem what we face is 30% patient who progress very early. And if those patients are HER2 low and they are progressed very early means within one scan those patient progressed. So these patients if they are HER2 low, probably those are the patients which will be benefited by it more. And those are the patients which are probably having more bone only disease. So they are probably getting a biopsy benefit.
So, in what setting? First line, second line, third line, fourth line. So where you put this molecule TDX in fourth line or third line?
At least, so sir, biology is important. If somebody who is hormone receptor refractory, means we all have seen patient जिसको रेबोसिक्लेट पे या किसी पे भी डाला हार्मोन के साथ पहले स्कैन के पहले पेशेंट प्रोग्रेस कर गया. So that patient is never going to respond to any hormone. If that patient is too low, probably we can give the agent to that patient.
So apparently we can add, or if we can give the chance
We
of
can
if the
the trial
chemo
had
and
patients.
chemo followed by this.
Probably chemo doesn't work in those patients. That those patients are nightmare. If they are too low, probably we should go.
In
Because in
your
this,
experience with this drug in HER2 low, have you
I have
used?
not used it, although I have advised it, but experience with 3 other patients who progressed on CDK4 inhibitor within 2 months of the therapy were very dismal with chemotherapy.
Okay. Sir, is there your experience with this molecule in this HER2 low positive?
No,
Sir, even in this HER2 HER2 positive metastatic setting, the role, have you
all
tried?
as per the guidelines, yes. There is the wide separation of the curves, looks very promising because it's a ADC. So we feel that there should be this should be better than the combination of the pertuzumab and the other combination, including the TDM1 molecule. It's a
Okay.
stronger drug.
So, sir, in HER2 positive patient, can we put on earlier lines if the progression on the trastuzumab in
अभी
future?
तो बस second line में approval है.
No, my understanding, this is approved versus the TDM1.
Yeah.
Yes, sir. For now it is TDM1 on the place of TDM1.
Sir, in
Line one
future,
is
So let's say
in future,
the clinical scenario is there where you want to use it in the first line in place of the TDM1. It's approved after trastuzumab exposure.
yes.
Let's say that the patient still has not been exposed till the second line. Let's say somebody has given lepatinib and capecitabine. So I think it's still in contrast to the TDM1, you should give it logically.
okay, sir.
Even sir, the previous trial of this drug, where this drug was used in third and fourth line, almost 20% patients were exposed to TDM1 and the drug was effective on those.
And we should not forget that the drugs like TDM1, they have failed in the neoadjuvant and adjuvant
Yes,
setup.
sir.
In classical way, neoadjuvant setup. So these drugs are basically in the first line or subsequent line in contrast to the other anti-HAR single agent or combination. It's a stronger ADC, I will say, in contrast to
Yes.
the TDM. So wherever
is-
you feel that the TDM1 can be used in a metastatic setting, you can use it. Till you have the mature data of the adjuvant setting, because neoadjuvant TDM1 has failed.
Sir, do you think that this is the game changer molecule, even in HER2 low or even in HER2 positive patient?
Because data is very strong.
So yes, because HER definition itself has changed because of these sort of drugs or the concept. What you should label as the HER negative. Previously means all 1 plus 0 and 2 plus FIS negative or the negative only for that purpose. Now we don't talk, we talk about the ultra negative, ultra low or the low 1 plus and the 2 plus certain sort of this thing. So definitely it's a game changer. It's a new avenue for the management of the ER positive patient with the carrying the HER low like 1 plus or 2 plus FIS negative patient.
Okay, sir. Thank you. Thank you, Jitendra, for this talk. And
Thank you,
moving
boss.
forward, so I invite Dr. Bala Stalin Chaudhary who is the associate professor in the Department of Medical College, Nizam Institute of Medical Science, Hyderabad. And he will moderate a panel on management of HR positive, HER2 negative cancer, Jaipur. Dr. Sudhir Palsania, the medical oncologist at Shelby Hospital, Jaipur, and Dr. Lalit Sharma, who is the medical oncologist at Manipal Hospital, Jaipur. So over to you, Stalin sir.
Yeah, thank
Sorry,
you.
sir,
Thank
for
you for
delays.
this
Actually.
opportunity.
Sorry, sir, for
Yeah,
delay.
yeah. So many of the things have been discussed in the last talk itself. So what I am going to discuss, so it is predominantly on the ER positive and the HER2 new and predominantly the HER2 low breast cancer, which we have been discussing over the last half an hour. Next slide. We know that these are the classical three subsets. So since 2 decades, we are treating the cancers in the concept of either they are ER positive or HER2 positive, which are 3+ or 2+ FISH positive, and the triple negative. And with the availability of the ADCs, especially the trastuzumab deruxtecan, the spectrum has widened, and we now have a concept called HER2 low, which are 1+ and 2+, for which the as according to the previous talk we had seen, the trastuzumab deruxtecan has changed significantly. So because of the short of time, we'll discuss the key concepts, what we do in our routine practice, and we'll try to wind up as soon as possible. The next slide. So coming to the ER positive MBC, Dr. Mukesh Ulania. So a key takeaway. So do you differently manage a ER positive subset in the first line with bone-only metastasis, with visceral disease, or with visceral crisis? 3 subsets we will have. So how do you typically manage in your routine practice?
So if patient have only bone only meds, then we start CDK4/6 with endocrine therapy. And if patient is severe visceral crisis, like increasing OTPT or lung due to patient is symptomatic due to lung metastasis, then we start with chemotherapy.
Okay, next slide. So, Dr. Mukesh Chaudhary, what is your second line of treatment and your experience of alpelisib?
Yeah, a patient progresses on first line CDK4 with endocrine therapy, and we tested for PIK3CA mutation and found positive in the liquid biopsy or on tissue, and then we start with alpelisib with second line fulvestrant. And patients are doing well. Many patients receiving alpelisib with fulvestrant.
Dr. Mukesh Chaudhary, are you there?
Right. I think Dr. Mukesh is not there. Dr. Lalit and Dr. Sudhir is there.
Sudhir. Yeah, thank you. Dr. Sudhir, so what are your thoughts? So any experience of using alpelisib? And I had few patients, but they are not tolerable and I stopped in between them. So quite a problematic drug to use in routine practice, according to me.
Yeah, but in the PIK3 positive is there, then we can try for the alpelisib with the fulvestrant only.
Yeah. Next slide. So majority of the times I use only fulvestrant alone because a lot of tolerance issues with a drug like alpelisib. So
Yes,
first
sir.
line, my practice is AI with CDK4/6 inhibitor, and second line, I will try to start alpelisib, but majority of the times I'll land up in giving only fulvestrant as a single agent. Then in the later lines of therapy, the concept of HER2 low has came. Next slide. And this has already been discussed, the HER2 new, the HER2 low concept and the HER2 ultra low concept and the HER2 negative, which was discussed in detail in the last slide, previous talk. Next slide. This is the distribution of HER2 negative. So Dr. Sudhir, what is your routine? Previously, we used to do only ER positive disease and HER2 positive disease and triple negative disease. So now with the concept of this HER2 low concept, so how many patients do you see as a HER2 low disease in your routine practice? If you see 100 breast cancer patients, you take metastatic, non-metastatic, how many will be on an average HER2 low?
Sir, HER2 low mainly in the triple negative disease is there. Then the HER2 positive is there, and then hormone receptor positive is there. If the TNBC, then around lagbhag 1/3 patient or positive for the HER2 low.
So, Dr. Lalit?
Yes, I would
So, Dr. Sir,
consider
yeah.
amongst if all patients considered altogether around say 40 to 50%. But if in hormone positive, the number might be slightly higher, say 50-55%. We haven't compiled the data, but that is the general kind of idea.
Yes, sir. This is the depicted the publication according to the HER2 low. So a slightly higher percentage in the hormone positive than in the TNBC subsets, and around 30 to 40% can be HER2 low in our routine day-to-day practice. Next slide. So coming to the trastuzumab deruxtecan extensively discussed this. This is one of the most potent antibody drug conjugate which was developed to treat the HER2 new positive disease initially, later moved on to the HER2 low subset disease also. Next slide. This is the Destiny 4. It was discussed in detail. I'm not going to the trial proper. Next slide. This is next slide. So, Dr. Sudhir, are you okay with the trial design and the outcomes of the Destiny? So, what's your key takeaways from your personal opinion on the Destiny 4 trial?
Yes, sir. There is data for the patient with the HER2 low is very promising with the PFS also and trial design also, but there are the less clarity about the hormone positive patients are there.
Dr. Mukesh Rulania, your opinion on the trial design and all other aspects of the clinical trial. You are very convinced with the data, or any flaws you find in the trial?
No, the data is very strong because the patient already received at least 1 to 2 lines of therapy, and the patient have limited option in this HER2 low positive metastatic breast cancers. So trial design, I think this is okay with coming to because this is trial in later line setting. So I am comfortable with this design.
Okay. Next slide. So these are the few facts. So according to the trial, so 21% are initially screen failure, and there is no platinum in the control arm, which we routinely use in cases of TNBCs or in the later lines of ER positive disease. And the trial is not a 1:1 randomized trial, and it is a 2:1 randomized trial, and that is okay in later lines of therapy. We do accept because majority of the trials are designed in such a way. Next slide. But the only problem is, so majority of the patients in the post-progression in the treatment of physician's choice has not received the TDXT. Only a very limited number of patients has received. So that may not be an ideal thing in a well-designed randomized trial. Next slide. So these are the overall survival results in the hormone positive, as previously discussed, a significant survival benefit in terms of both progression-free survival and overall survival. Next slide. And this is in the triple negative, that is the hormone receptor negative subset. So, but the population is only very little in the trial, the hormone negative population. Next slide. But there was a significant benefit in those population also. This, according to the subgroup, so all the patients has significantly benefited in terms of the OS. Next slide. Next slide. So these are the key takeaways from the trial. So post-progression therapy details are not there in detail, and there is no difference in either 1+ or 2+. So the drug has worked equally in 1+ and 2+. And for post 2 cycles of chemotherapy and age above, the confidence intervals are above 1. And as I previously told, the hormone receptor negative patients are only very smaller subset, represents only 58 patients, and majority of the patients included in the trial are the hormone receptor positive patients. Next slide. So practical aspects, Dr. Lalit sir. So do we do routinely biopsy at every progression, and you are classifying all your patients as HER2 low and HER2 ultra low at progression?
Because ideally, we would love to go ahead with biopsy at progression, but in a practical world scenario, I believe not more than 60 to 70% are be able to kind of biopsy at progression. We would like to reclassify our patients at progression regarding HER2 also, and probably go ahead a lot as per the reclassification at the time of progression.
Dr. Mukesh Rulania, So your pathologist is confident in distinguishing the HER2 positive disease 0 and ultra low, because across trials we had seen that there are inter-observer variabilities in reporting the HER2 new positivity. So does your pathologist know the concept of HER2 low, ultra low, and HER2 0, and the availability of new drugs and the clinical impact of reporting of these HER2 low concept?
Currently, our pathology reported at HER2 0, 1 or 2 or 3 plus. They are not separately reported ultra HER2 low and HER2 low disease. Currently, they reported according to initial scoring 0, 1, 2, 3 at our center.
Okay, next slide. So this is HER2 low and ultra low. So already discussed a bit. So because of the time, I'm skipping. Next slide. Next slide. Next slide. So now the question. So for HER2 low and ER negative patients, so we now have two possibilities. Previously, they are called as TNBCs. So we now have two options: TDXD, the trastuzumab deruxtecan, and saxatumab govitecan. So Dr. Mukesh Chaudhary, so what do you prefer in these patients? Classically, before reporting of this HER2 low, so these are considered as the TNBC patients, and there is a data of HER2 new positivity reported from the saxatumab govitecan trial also. So if at
Yes,
all
yes.
you come across a patient, so what do you prefer?
So there is no head-to-head comparison between these drugs, both drugs, and we have only available at present trastuzumab deruxtecan. So I would propose trastuzumab deruxtecan. We have no secukinumab govitecan at present.
Dr. Mukesh Chaudhary, any thoughts?
I think sir, Dr. Chaudhary is not here.
Okay, Dr. Sudhir.
Yes, sir. There are the data for this SG also for, but as Mukesh said, there is a no head-to-head comparison with the TDX1. But if it is the HER2 low, then we go for the TDX1 also.
Okay, next slide. So this is the data which was presented according to HER2 new IHC status. The saxatumab govitecan also showed positivity in the HER2 1 plus and 2 plus studies, and typically these two are options. So there is no head-to-head comparison as previously discussed, and we can sequence one by one in this population too. Next slide. So Dr. Lalit sir, so what is your experience of using this? And there is a lot of buzz regarding the development of ILD, and the significant number of patients develop ILD. So what is your clinical experience of using this drug, and the toxicity profile you have seen if you have used this drug?
Well, sir, so far, touchwood, say around 4 or 5 patients are there in whom I have used this drug. And the maximum PFS which I've so far got is 6 months plus. Thankfully, none of them has developed ILD. But to be on the safer side, we are doing HRCT every 3 months and DLCO every 3 months. Thankfully, none of them has developed so far.
Next slide. Next slide. So significant number, so almost 20 to 25% developed, and possibly it is problematic to use in patients who already have a bad lungs, either due to the disease or because of previous coexisting lung comorbidities. Next slide. And this is the real world data, perspectives and practices for pneumonitis and interstitial lung disease with trastuzumab deruxtecan. Next slide. So 15.3%, the pooled analysis of non-studies. So almost 1 out of 6 patients will develop it, and median time to onset was 4.3 months, and 2.2% we have a grade 5 event, that is death due to this interstitial pneumonitis. Next slide. So definition, because of the time, I'm skipping these slides. Next slide. So we all know this drug causes significantly in interstitial pneumonitis, and grade 3 and above will permanently discontinue it, and grade 1 and 2 you can rechallenge. Next slide. So any concept, Dr. Sudhir, do we use
Yes, sir.
TDM1 for HER2 low?
Sir, there
So
is a node in the HER2 low only TDX1 because it is
because
more
both are antibody
more
drug
potent in the.
conjugates.
Yes, sir.
Both
It
are
is more.
antibody drug conjugates. Yeah.
Yes, sir, it is more potent than the TDM1 in the efficacy in the antibody conjugate. Both are there, but TDX1 is the upper hand to the TDM1. Indirect trial is there, and HER2 low only TDX1 is approved according to the data.
Next slide. Yeah, we have some data to say that TDM1 is not as a robust antibody
Robust
drug
data.
conjugate as
Yes, sir.
TDXD, and it shows that TDM1 doesn't work in this HER2 low subset, and we typically don't use TDM1 in HER2 low subset, and TDXD is the only drug we are going to use. Next slide. Next slide. Dr. Mukesh and Dr. Sudhir. So what is your experience of using this TDXD? Next slide.
I have not used till date TDXD.
I also have not used, but sir, there is a 50 mg problem is everywhere. Costly
Yeah.
drugs. So maybe round off is better, sir. Like 344,
Yeah.
300 is better, sir.
Yeah. Okay, fine. So typically we tend to round off to the lowest possible value and give it to the patients.
Yes, sir.
So to conclude, so TDXD especially is a game changer in breast cancer. We have seen its outcomes in the HER2 positive disease and especially in the HER2 low disease, and the trials are happening in the adjuvant and also in the neoadjuvant setting of the HER2 positive breast cancer. Possibly it significantly will change even in the non-metastatic breast cancer, how we treat the HER2 positive disease after the publication of those results. And significantly, it is a very potent antibody drug conjugate and is an ideal choice in later lines of therapy in the HER2 positive disease. I thank Dr. Mukesh, Dr. Sudhir, and Dr. Lalit for their wonderful comments.
Thank you, sir.
And I thank organizers for this opportunity. Thank you.
So thank you, Stalin sir, and thank you all my panelists for this wonderful panel discussion. And I conclude the second day of this the Oncology Perspective the conference's virtual webinar. And yesterday we have discussed about this lung, and today we have discussed about this GU, GI, as well as the breast cancer. And it's a very well discussed by the all the speakers, as well as the moderation was very well done. And thanks to all my the speakers, as well as the moderator, as well as the panelists, as well as the all attendees. And thanks to the all pharma companies for sponsoring this the conference. And thanks to the Horizon team who make this the virtual webinar successful. So thank you all. Good night, and we'll meet you soon with another webinar in next few months. Thank you.
Good night, boss.
Thank you, sir.
Thank you.
Thank you.
Support team, please close the meeting.